Good afternoon, everyone, and welcome to the Rural Emergency Hospital Educational Webinar and Fireside Chat. We are so excited to have with us today two hospital CEOs who we will be chatting with a bit later in our presentation. We have a packed agenda today, and we're going to start by giving you a brief overview. If you've joined us before, some of you may have seen this information, but if you're not familiar with the REH designation, we're going to go over at a high level the policies and requirements of being an REH. We're going to talk a little bit about the Rural Health Redesign Center and the technical assistance that's available. And again, we're going to have a fireside chat. Ken Harmon, our program director, will be leading that discussion with Aaron Herbel, the chief executive of Mercy Hospital in Kansas, and Melissa Gale, the CEO of Landmann Jungman Hospital in South Dakota. We'll close out our time today with resources and next steps. As always, we want to note that the work of the Rural Emergency Hospital Technical Assistance Center is funded by the Health Resources and Services Administration, also known as HRSA, from the U.S. Department of Health and Human Services. The Rural Health Redesign Center provides technical assistance to organizations on behalf of HRSA. While we strive to offer accurate and up-to-date information, the information provided today is for general informational purposes. Today, we have Ken Harmon, the Program Director for the Rural Emergency Hospital Technical Assistance Center, as our speaker. My name is Amy Kaltenbach. I'm a project manager here at the RHRC, and I work in supporting the Rural Emergency Hospital Technical Assistance Center. I'll be your moderator today. Ken brings a background of over 30 years of healthcare experience, with 20 years in being a rural critical access hospital CEO. He's served in Wyoming, Colorado, Idaho, California, Utah, and Minnesota. He graduated in 1996 from the University of Minnesota with a master's in healthcare administration, and from the University of Utah in 1990 with a bachelor's of science in economics. He has a passion for rural healthcare and in assisting organizations and communities in sustaining and growing to take care of their community needs. Before we get started, I want to go over a few housekeeping items. You may notice that everyone is on mute, and this is to avoid background noise. When possible, we ask you use the webinar link to log in rather than the call-in option. This will ensure that you have the best audio quality experience. We encourage you to ask questions. Please use the Q&A feature. This will be found either at the top or bottom of your screen, depending on the layout. If you need closed captioning, this is available. To access, please click More with the three dots at the top of the screen, and then select Language and Speech. Finally, choose Transcription for the closed captioning. The slides and recording from today's webinar will be available on our website at rhrco.org within a week after the event. If you have any questions, please reach out to us at rehsupport@rhrco.org. I want to go over our objectives today, which are to provide you with a high-level overview of the REH, review the REH policy and requirements. We want to share information about the Technical Assistance Center and the services we offer to rural emergency hospitals. And again, most of our time today will be spent in a fireside chat with our CEOs. So with that, I'm going to turn this over to Ken, and he's going to give us a brief overview of the REH and talk about the technical assistance that we have available here.
Thank you very much, Amy. I appreciate that. We'll start off and talk just a little bit about who we are as the Rural Health Redesign Center and the Rural Emergency Hospital Technical Assistance Center. Our mission is to promote and protect access to high-quality healthcare in rural areas. We do this through partnership. We have a lot of organizations that we work with that assist us in doing that to improve the health and the wellness of these rural communities that we're serving. And so I count it an honor and a privilege to be able to speak and work with these hospital leaders like Aaron and Melissa and others each day, and to be able to have our team provide the education and guidance on the rural emergency hospital program, and to come alongside these leaders and provide the technical assistance they need to be able to take care of their communities. The REH program is really designed to help facilitate the ongoing uh, provision of services in these rural areas. We had a lot of rural hospitals that were struggling and that were starting to close. And so this program came out and was established to avert the potential closure of rural hospitals and for the to allow the continuation of these essential services and to make sure that people have access to the care that they need. This was done in 2020 with an effective date of January 1st of 2023. And we have 44 REH hospitals currently licensed, and another 5 or 6 that have applications in process. And so it has been a wonderful opportunity for us to help these hospitals and to do that. This rural emergency hospital was created to give the rural communities some options to be able to work as a emergency and outpatient care facility. And again, this is the newest designation and the first designation of a provider type since 1997. So very, very exciting to be able to see that happen. In order to qualify for an REH, there's a few things that these hospitals have to be. Number one, they have to be in a rural area, and they have to be licensed as either a critical access hospital or a rural prospective payment hospital with fewer than 50 beds. In addition, they have to be a licensed Medicare provider. In fact, have to have been licensed on December 27th of 2020 when the law was passed. They have to meet staffing and other certification requirements. They have to ensure that they meet not just the federal requirements, but any specific state requirements. In the REH program, there's a 24-hour average length of stay requirement for all of those OPPS-based services. And they have to be able to make sure that they have a transfer agreement with a level 1 or a level 2 trauma center, since the hospitals that are rural emergency hospitals are no longer providing inpatient services. They have to be able to have agreements with those hospitals that can take those patients. And they have to put together an action plan or a transition plan, really detailing the types of services that they're going to continue to offer in their community and the types of services that potentially they can grow into providing. So that's just a little bit about some of the eligibility requirements for the rural emergency hospitals. Rural emergency hospitals are required under statute to provide certain services. They are required to have 24 hours a day, 7 days a week emergency room and observation services available for the patients that come into their hospital. They're required to be able to have diagnostic lab and radiologic services. They have to be able to have the medications that these patients need while they're in the emergency room or in those observation stays. And they have to be able to have a process ensuring that adequate discharge planning is occurring for those patients who are leaving the emergency room or who are leaving those observation stays, whether those are going home or whether those are being transferred to other facilities. They can also offer a lot of other services. And so effectively, almost any outpatient service these rural emergency hospitals can operate. I'm not going to read the entire slide here, but I'll point out a few. Most of the rural hospitals around the country are able to continue to provide outpatient care for their patients who come into the hospital, whether that be infusions or Some of them are doing outpatient surgeries. Many of the rural emergency hospitals have rural health clinics or primary care clinics associated with them, either as part of their organization or in partnership. And so all of those type of services continue to be able to be offered and continue to be able to be provided by the rural emergency hospitals. Um, just giving maybe a quick overview of what's included and not included in a rural emergency hospital and some of those payment mechanisms. Um, First and foremost, there is a monthly facility payment that is made to these rural emergency hospitals. It was $3.4 million after sequestration in 25, and it's going to be up closer to a little over 3.5 million in 26. These That is the funds that is helping many of these financially distressed hospitals keep their doors open. In addition to that monthly facility payment, these hospitals are receiving increased reimbursement for their outpatient prospective payment system, outpatient services. So any of those services that fall under that OPPS system is getting the Medicare rate plus 5%. Like all programs, there are things that they gain and there are things that are losses. The things that the hospitals that choose to become rural emergency hospitals give up is they're closing all of their inpatient services and all of those services that would have been billed under an IPPS or a inpatient service. So that includes inpatient services, that includes swing beds if they're in the hospital. They are not currently eligible for the 340B drug program. And for those hospitals that were critical access hospitals, they no longer have that cost-based reimbursement. As we have conversations with hospitals that are evaluating this program and we put together this financial model to help them, it's important that we look and we add those things up and we subtract those things out to ensure that these hospitals can look at and to understand what's going to be occurring or potentially could be occurring for those hospitals as organizations. For those organizations, once they've worked with us and completed their financial model and they've had the discussions with their medical staff and their boards and decide that strategically applying to become a rural emergency hospital is the right thing, we come alongside them and help them with the application requirements. The organizations are required to do really three things federally, and some states have a couple of additional requirements as well. But so today I'm just going to really be talking about those federal requirements. There are really three when they apply for the application. They have to put together an action plan or this transition plan, which includes a description of all of the services that they have, those services they will be discontinuing, those services they're going to be continuing, and any potential services that they would be looking to add. It also goes through and talks about the staffing provisions and how they're staffing those services that they're going to continue having. And it goes through and provides a description about how the organization is going to be using that monthly money that's coming in. Whether that's to pay for the operational expenses of the hospital or in some cases looking at adding certain things and helping to grow the provision of care and services in their community. They also are required to have a transfer agreement, as I said previously, with a level 1 or level 2 trauma center. And when the application is submitted, they have to turn that application in as well. And they have to do an attestation. This is not a new hospital application. This is a change application through the PACO system or using an 855A application. And so because it's a change application, this attestation serves as that initial commitment that you're currently meeting all of the existing conditions of participation and a commitment on behalf of the organization that you're going to continue to meet those conditions of participation. The Rural Emergency Hospital Technical Assistance provides a lot of support for hospitals, both on a pre-conversion basis and on a post-conversion basis. On the pre-conversion basis, we come in and we assist them and get a lot of education around the program. Um, you know, we have multiple hospitals. I think this week alone, we've had 3 or 4 hospitals reach out and want some introductory information about the program. And we provided some basic information for that and have invited them to participate in a very in-depth educational session, either in January or February, where they can get every question answered, and we can go into great detail about what are required for the conditions of participation, what are required for success in the program. In addition, we provide and continue to assist these organizations in providing resources to help them to be able to communicate and share this information when it's appropriate with their board, with their medical staff, with their employees, with their community. In fact, just 3 weeks ago, I was helping a hospital in Nebraska as they were communicating with a community meeting to be able to talk about why they were looking at this as an option and what could the community expect to be able to see out of their hospital, and how they could continue to meet those needs of the community. And so we're doing things, giving them tools, and also having liaisons come along and support these hospitals in those processes. We also obviously help them with the applications. We will review and provide templates and assistance in putting together the action plans and reviewing the attestation and reviewing their transfer agreements to make sure that they are in fact with a level 1 or a level 2 system. We also work with hospitals and help them put together this financial model. This model is very helpful for these hospitals to be able to have kind of an apple-to-apple comparison. They could compare what was my status as a small PPS hospital and what would I be financially looking like if I became an REH, or what was my hospital performing like as a critical access hospital, and what could I expect to see my performance look like as a rural emergency hospital. And we go through, and we have a partner who assists us in that. That's Mathematica, and we go through, and sometimes we have one model we do. Sometimes we have multiple models for hospitals. I have one hospital in Kansas that we're actually putting 3 or 4 different scenarios together. So their board wanted to be able to look at and see different types of parameters. And so helping provide that financial model so those organizations have the information in front of them so they can make those decisions. We also are willing to come alongside and help kind of facilitate the conversion process, taking that action plan that these hospitals have and kind of putting it into an accountable action plan so that we can assist the organizations in being successful at implementing those things that need to be done. And of course, a lot of additional technical assistance that's done post-support. A lot of that is on financial support. We also do a lot of that around regulatory compliance and quality in strategic planning, just to name a few of those areas. But again, all of this technical assistance, whether it's done pre or post, is always provided at no cost to the hospitals, because those services are provided under those grants from HRSA. The conversion process takes a little bit of time. Obviously, they're going to take some time to determine whether this is the right thing for them to do. Here we tell you it's maybe 1 to 3 months. I've seen some hospitals make their determinations because of the financial struggle and the processes that they're in, that they make these decisions within a week or 2. And we've had some hospitals that have taken a couple of years to make that decision. So that assessment time of 1 to 3 months is really varied depending on the factors that the organization wants to consider and what they're looking at. The application process, once they get that application and get it submitted, traditionally it's around 3 months. Sometimes a little longer if there's questions that need to be asked. Sometimes but not often, a little quicker. We tell people usually 3 months to expect. And then they're going to pick a date, an effective date. Sometimes those effective dates fall during that 1 to 3 month conversion process. And if that's the case, they have to be living the standards on the date they put for their effective date. But they'll pick that date, and then we come alongside, obviously, and help them put together some documents to assist them in that conversion process. And we've already talked about the ongoing support that continues for hospitals. We're going to transition a little bit into the fireside chat. So I'm going to turn it back over to Amy, who is going to do our introductions of our CEOs. So Amy.
Thank you, Ken. We're very excited today to have two CEOs with us, and I'm going to briefly introduce each of them to you. Aaron Herbel is the Chief Executive of Mercy Hospital in Moundridge, Kansas. He served as administrator since April of 2017 and as CFO since February of 2019. He leads the facility in meeting the healthcare needs of the community by exempling compassionate leadership. He piloted the organization through the COVID-19 pandemic and through several years of financial uncertainty. A chief accomplishment has been the successful transition to the new rural emergency hospital model in early 2024 to ensure the financial sustainability of the organization. In his spare time, Aaron enjoys reading, writing, traveling, and spending time with his wife and 4 children. Melissa Gale, MBA, is the CEO of Landmann Jungman Memorial Hospital in Scotland, South Dakota. She's worked in the Avera Health System for over 15 years. Her combined background in rural health, agriculture, behavioral health, clinical quality, population health, community leadership, and business have helped her lead innovative rural health programs and navigate the hospital in Scotland as the state's first rural emergency hospital. Now I'll pass this webinar back to Ken to have the discussion with our REH leaders.
Well, thank you very much. And again, we'll bring up if there's any particular questions that you have about the REH program or you would have for these two CEOs, please put those comments or questions in the Q&A session and we'll be sure to get them. But maybe we'll start with you, Melissa. Can you walk us through the process that you and your organization did in deciding to become an REH?
Yes, thank you, Ken. I would be happy to. So we actually started looking at REH right after it was adopted. So we knew it was coming down the pike. There had been other legislations that had attempted to do some fixes like REH prior that didn't go through. So this is something that had been on our radar even before the 2020 act that got this to go through. So right when that went through, we started almost taking a dual track. So we were a critical access hospital. So we started looking at, okay, what are we going to look like as a CAW moving forward? And what would we potentially look like as an REH moving forward? So we did what I would call significant due diligence, looking at volumes, our acute volumes, swing bed volumes, outpatient, those kind of things, just to know what that looked like. And our acute volumes had been extraordinarily low year after year. We're in a very small town, so not too surprising, and we're a small organization. But ultimately, about 99% of our revenue came from outpatient already. So there wasn't a lot of inpatient volume. And then we obviously looked at all the different financial factors. We did multiple different kinds of modeling. We did modeling like Kent talked about in conjunction with Mathematica, and did several scenarios. I had also had modeling done the previous 2 years with other organizations, and done some myself, and it all aligned very closely. And we have a large Medicare Advantage population, so we had to look at how Medicare Advantage may play into this, which I know is a factor for some more than others. So on top of the financial and the volumes, we really took a deep dive into how is this going to affect our workforce? How is this going to affect our community and just economic stability of the community? What are the different regulations and where do we get positive wins on some deregulations and things that we would no longer have to manage and balance all at the same time? How does this affect our partners in the community and within our region? And how would we be able to expand and maximize some of our current outpatient things, as well as looking at additional things in the future? So we looked at all of that for literally a few years. So I feel like we did a really good job about due diligence. Our board members were highly educated. They did a lot of education sessions. We talked through a lot of things. And then when the decision was made in March to convert in March of 2025, that is when we started rolling out conversion towards REH. So we were officially converted July 1st, 2025. So we're very new. We didn't get our new CCN PTAN number until the end of September. So still kind of working on a few things in the transition, but overall we were operational as a REH July 1st, 2025.
Thank you very much, Melissa. Aaron, maybe I can ask you to kind of walk us through the process that you and your community did in looking at and deciding to become an REH, why you did it, and those processes.
Thank you, Ken. Appreciate the opportunity to be here and share a little bit of our story. And we would have many similarities with some of what Melissa was just referencing. Historically, we were a small PPS hospital. We had a very active medical staff. We actually had 6 full-time family practice physicians that were admitting patients to our hospital. And so when I started here in 2017, inpatient revenue was comprising about 70% of our total net revenue in a year. And at that point in time, we wouldn't have even considered a transition. But in the 8 years subsequent to that, our inpatient volume as a percentage of total revenue was just continuing to decline and decline and decline. And the last year that we had any inpatient, it was only about 40% of our total revenue. So seeing those volumes decline, knowing that not only was the cost and the staffing burden to continue to provide inpatient services increasing, but with the declining volumes as a PPS hospital, we weren't able to justify it financially for our organization on the balance sheet, or the profit and loss. And so, as Melissa referenced, we had been looking at the REH since it first came out. I still remember the individual who was our board chair when we made the decision to convert. He wasn't the board chair then, but we were in Kansas City for a hospital association conference, and KHA first presented this as a possibility, and he looked at me and he said, I think that's the model that Mercy's going to operate under. And it was almost 3 years to the day from that point in time when we made the final decision to submit the paperwork and get that process started. So it was a process. I think a key part of that is making sure that all of our stakeholders were engaged and aligned. Many conversations I had with those physicians, those 6. Now today, that's 8. We actually have 8 MDs in our community. One of those is employed by the hospital, and the other 7 are independent contractors. But seeing them align their business model as physicians and get behind the hospital and say, we feel like this is the best model for us moving forward, was really helpful for our community in also aligning and saying, we can support this as well. I think when you have the physicians in a community who are kind of aligned opposite of the hospital with regard to future plans, that's not positive for the community. And it can lead to internal strife within the organization and also in the community. Anytime you have a small community, everybody knows everybody. And I think the physicians in the community carry an outsized weight with the community in terms of what they feel about the direction for the healthcare and the hospital specifically. And so I think that's an important piece to engage early in that process, is making sure that the physicians are aligned strategically with the hospital and that we're all working together for what's best for the community. Our process was, I felt like, fairly seamless. As far as an actual transition, we submitted our paperwork in October of 2023, and we officially started operating as an REH January 1 of 2024, and got our official approval letter from CMS with our new CCN on February 6th of 2024. So just over 4 months for us, and that involved some of that time over the holidays. So that definitely slowed things down. But overall, a very, very pleasant experience, I would say. And we had good engagement from our state senators when we needed to help with some things at the federal level. So
Thank you very much, Aaron. I might drill down and ask you to share a little bit. Tell us a little bit where the organization was financially, and because of becoming an REH and all of the other changes that you've made since, where you are today.
yes, Ken. That is, I feel like, really, like my little bio said earlier, a successful transition to a rural emergency hospital. We were coming off of 7 years in a row of negative operating margins, significant negative operating margins. The 2 years prior to conversion were both minus 20% or more negative operating margins. And so we were coming in with limited days cash on hand, limited ability to replace equipment when it needed to. It was a challenge to continue to provide those things. The first partial year that we operated as an REH, we made a significant improvement on that. And we just closed fiscal year 25, which was our first full 12-month period operating as an REH, and we had a positive operating margin of 1.49%. So, that's a tremendous turnaround financially for our organization to the place where we can now, address necessary life safety upgrades in the facility, plan for the future, and ensure that our staff are receiving reasonable compensation for the work that they're doing, taking care of our community.
Thank you very much, Aaron. Melissa, I'm going to ask you, how has this transition been beneficial to your facility and your community?
Yeah, thank you for that. So I think we've seen benefits in a lot of ways. When we converted July 1st, it was just like a normal day. So our conversion wasn't necessarily under any panic situation. Although we didn't have great margins, we were, kind of stable at the break even perspective. So no one felt like it was a panic, which I think helped the staff feel very confident. They understood it and they knew why we were doing it. We had no loss of jobs, no layoffs, any of that sort of thing. So from a community and facility perspective, it was very helpful in that. And quite honestly, some of the things that were kind of pain points for staff went away. Lots of pre-authorization things on the inpatient side, lots of denials on inpatient authorizations, particularly for Medicare Advantage plans, lots of discharge planning with the swing beds. So some of those things that took up a lot of staff's time and could be frustrating at times were things that got to go away, which staff was very grateful for and very happy about. And then some of our hospital nurses have got to branch out and learn some other things, like they've taken on cardiac rehab and Planet Heart, which is a heart screening program that's available through Avera. And just some different things that help them still be in front of patients, but give them a little bit different look than what they've had with just inpatient and ER. So from an internal facility, all of that has been good. And then from a community perspective, in our area, generally with EMS, just like every small town, emergency services is difficult. They're all volunteers, and if they have to take a transfer out to Sioux Falls, which is the closest large hospital to us, it can be 6 hours because it takes about 2 hours to get there by the time you load the patient up, a couple hours to get back, and then the transition time. So we have partnered with other critical access hospitals. We're all Avera hospitals in this region, so the partnerships were very simple and seamless to put together. So we can transfer to hospitals now that are 35 miles away. So it takes EMS less time away from their families. It makes it a lot easier for them, and it makes it easier for patients as well if they can be transferred to a closer place. So that's really nice to do there. And then our local nursing home. We do have a nursing home here that is a Good Samaritan nursing home that we've always been highly involved with. We're actually their medical director at the nursing home as well. And this gives them an opportunity to get more skilled patients, whereas, quite frankly, we would somewhat fight over them, so no need to do that anymore. So they're getting some better reimbursement on skilled patients because we don't have swing beds anymore. So we kind of looked at it from those perspectives in the community. And our city has been very helpful and very on board as well with just making sure that the correct information gets out into the community as well as we've went through this process. So from a facility and community perspective with those things, it's been a lot of wins in our community.
Thank you very much, Melissa. Aaron, maybe you can talk about, since you've opened as an REH, how have you looked at the community needs and what kind of things have you added as additional services to help take care of your community?
Yeah, that's been an exciting thing for me as a leader for our hospital, to see us be able to provide more services, and the number of patients that we're able to meet where they are and provide needs for their community, for their personal health, has actually increased substantially. So after we converted to an REH, we opened a walk-in clinic in our community here. It's open 4 to 8 p.m. Monday to Friday, and then in the afternoon on both Saturday and Sunday. And that's been a tremendous opportunity for us to provide care for kind of that middle age group population. So we've got parents with children, probably school children, and even toddlers and young children also. But then that working age population, historically, that wasn't a demographic that we were able to really reach with our inpatient unit and with our swing beds. Most of them can drive out of the community for care, and they did. But that has been very exciting to see those patients be able to stay in the community and receive that care after hours, after the primary care clinic closed. They can come in and get everything from a pre-athletics physical to, they just need an antibiotic for a minor infection they're dealing with, or want to make sure they don't have a broken ankle, those kind of things. So that's been exciting for us. We've also seen significant expansion with our outpatient infusion center. And we always did a little bit of outpatient infusion here as the hospital. The patients would come over from the clinic next door and, be here for a couple of hours for IV fluids or for a blood transfusion or iron. But we've really expanded the drugs and the infusions that we're doing through that service. And so therefore, the number of patients that we're able to care for that can stay in our community. Our local clinic was not able to continue providing that service because they were losing too much money at it, that they decided they didn't want to keep doing it. So the hospital's able to pick up those services and make sure that those patients can still receive those in our community. And I think we're seeing about 4 times as many patients in our infusion center on a monthly basis compared to pre-conversion. So that's been a big win for our community also. And we've continued to grow our outpatient physical and occupational therapy department. So those have been 3 areas of big growth for our hospital that have been beneficial to the community and really helped us to ensure that we're meeting those needs in a sustainable way.
Thank you very much, Aaron. Melissa, what were some of the biggest unknown or surprises or hurdles that you had come up during the conversion process?
Yeah, with all good things, there are some hurdles and some roadblocks sometimes. So I would say basically the biggest roadblocks that we ran up against was the length of time it took for us to be able to start billing again. So basically July 1st, we had to halt all billing, waiting for our new CCN number. And then we didn't get the new CCN number till September 19th. And if you guys can all remember, this is just kind of bad timing, but the government shutdown then happened on September 30th. So our tie-in notice got caught in that time frame, so to speak. So we were kind of just on hold literally till the end of October for the most part. And then November 7th, we were able to start releasing claims. So anyone that has ever had to sit on all their claims for that long when you don't have a plethora of cash gets really nervous, right? So I would say that that was probably the worst part of it. And now it's just a matter of getting some of those things caught up. So since we got that remedied and taken care of, all of our billings been out and fine, and just kind of waiting on 3 months worth of retro payments. But the normal payments now are coming in monthly. So that was probably the most unnerving for me. Of course, none of my staff knew this was going on. You know, the day-to-day people didn't know. So that was probably the biggest barrier, so to speak. I will say I know we're kind of talking about barriers, but I can't say how happy I am to be in South Dakota, because the South Dakota Department of Health and the South Dakota Federal Delegation have all just been outstanding to work with. So I think it was really important when we were running up against some of these roadblocks that we had help, and they would turn things around within literally hours if we needed something from them. So with some of the roadblocks, we did have a lot of help from Ken's team and just our great South Dakota family in at the Department of Health and the federal delegation. So I would say those would be our biggest roadblocks to converting.
Thank you very much, Melissa. Aaron, maybe you could share a little bit. How has the Rural Emergency Hospital Technical Assistance Center assisted you in, I guess, the process of conversion and since conversion, helping your organization achieve what you want to do and what your goals are?
Yeah, we were privileged, Ken, to be part of cohort number 2 with the Technical Assistance Center, which started July 1 of 2023. And so that was really our first deep dive into what exactly is involved with the conversion process. I was very thankful that REH-TAC made a lot of the resources that had been put out by CMS and HRSA about rural emergency hospitals available to us, so that we could dive into what is required in those action plans, what's the process to submit, helping us to find contacts within the government that were able to assist with questions that REH-TAC wasn't able to answer. I was very thankful for those. Anna, the project director at the time when we converted, gave me 2 different times a contact at CMS to get a question answered, and that was incredibly helpful for me at those points in time, because we were I think a fairly early adopter, and the MACs were just really starting to work through some of these applications. I think we were the number 2 application that our MAC had handled, and so within each of these layers of approval that were needed, the individuals processing these were not very familiar with the steps, and they were still kind of learning all together with us. And I was very thankful for the support from REH-TAC through that time. Helping to review our action plan and make sure that it included the necessary details. That was helpful for me. Once again, we were very early in the process, and so there wasn't a lot of precedent, if you will, for how exactly do we go about doing this. Very thankful for that, and been very thankful too for the support post-conversion. But even through that exact time when we got our approvals, it was nice to be able to have a team that we could kind of share that win together with. And so the RHRC group was someone that we could celebrate with too, once we had achieved that designation and gotten our approval, because they'd worked, walked alongside us through that journey. So that was very, very memorable.
Thank you very much, Aaron. Melissa, for you, if you had a magic wand and could change the REH laws and statute, what changes would you like to see that would benefit your facility and other facilities maybe considering an REH designation?
Yeah, so I think the first thing I would do with a magic wand would be to add 340B back to the REH program. So that is one thing that, of course, all REHs lose. That is one thing that we benefited from here being a critical access hospital. So it was one of the areas that we had to weigh and say, okay, is our 340B benefit worth giving up? In our case, it was, but I know in a lot of critical access hospitals, it isn't. And that is what is preventing some from converting that would potentially be a benefit overall. The other thing, so I have three things. My second thing would be that all outpatient services be paid at the add-on rate. So currently not all of them are. So I know a big selling point and what I think most people understand is that it's OPPS +5, but it's not like that on all services. That we do offer, even ones that are required to be able to be offered, such as lab things. So that would be one area. And then my third thing, which I don't really know if this would benefit everyone, but I would sure like it. Because we also, as a call, you lose cost-based reimbursement, which has its benefits and its risks. But ability to access capital long-term and large amounts of capital, even with a monthly facility payment, isn't going to take care of all of that probably at the end. So I would like to see maybe a consideration for a rural emergency hospital infrastructure grant program in the future.
Wonderful. Thank you very much, Melissa. Aaron, I'll ask you the same thing. With the magic wand, what would you do differently?
Well, and for our community, I appreciated Melissa giving the context for her community there and how they've been able to partner with that long-term care community for the skilled services. In our community, that would be the number one thing that I would like to see, would be restoration of swing bed services to a rural emergency hospital. And my reasoning for that being, in the analysis that I've done on the distinct part SNF, while it's an option for us, it's much more burdensome from a regulatory perspective. I feel like the additional burden that it puts on the facility from a regulatory perspective offsets many of the gains that we had in going from being a PPS acute care hospital to an REH. And there's a lot of redundant staffing that we would have to bring on board because you're subject to an entirely different set of conditions of participation and state regulations, even on the physical plant side, that we would be subject to. So it would cost us at least $1 million a year more to run a 6-bed distinct part SNF versus running a 6-bed swing bed unit inside our REH. And a lot of that is regulatory compliance and staffing. So really not anything that's bringing value to the bedside for patient care. And so if those services, those skilled services, could be provided in a swing bed that was licensed under the hospital, we would gain a lot of those efficiencies, particularly on the staffing side. So that's one thing for our community that would be a very big benefit. Our medical staff, our community members, and our board of directors all would still like to bring skilled back to Mercy. And so on behalf of our community, that's my biggest ask from a magic wand perspective.
Perfect. Thank you both. We appreciate, and we do note that there are legislative fixes that are being proposed that encompass some of those magic wand items, but not all. But that's up to Congress to determine what they want to do in that regard. So we've got a number of hospitals online listening and a number of support organizations for hospitals, hospital associations, state offices of rural health, and other What advice would you give to those organizations? We'll start with you, Melissa, as they're evaluating REH or trying to look at REH. What advice would you give them?
First of all, I would just say make sure you do good due diligence. So when you go to your community, you have a plan, you've looked at all the different angles, and make sure that you have allies in your state and in your um, local, state, and federal government that you can, even if you don't agree with them all the time on every issue, at least go to them and get some assistance when needed. So I would say uh, do a very complete job on due diligence. Make sure you're clear in communicating the plan, have a good communication plan, and use your allies in all of the ways that they can help you get through the process and continue to move your facility forward.
Thank you very much. Melissa, I appreciate that. Aaron, I'm going to ask you a similar question there, but maybe you can share. I know you did some creative things with your communication with the community. Share a little bit about how you engaged with the community in the decision process, but share what advice you have for others as well.
Yes, thank you, Ken. It was, I feel like, an important component of the overall success story that we've had through our conversion to a rural emergency hospital was the joint commitment that we do want to keep a hospital in this community, and then subsequent to that, the joint commitment that this is the best way to do it. My encouragement, first off, to follow up on Melissa's comments would be, yes, do that due diligence and don't wait too long to start it. Because, if a hospital is looking at their balance sheet, they're looking at their profit and loss, they're looking at their volumes, and they're saying, this is not headed the right direction, we need to do something different. Don't wait until you're down to single days cash on hand to try to start a process of evaluating whether a rural emergency hospital could be a good fit for your community. I've received some phone calls from other hospital peer leaders across the country who are interested in exploring this, and unfortunately, some of them are in that position, and they're like, "How quickly can I convert to an REH?" And Ken kind of addressed that earlier. The process is probably 90 to 120 days, maybe longer, to actually get some of that additional cash inflow. To Melissa's point about the claims that are going to be held up for a while, and so. Engage those stakeholders early and often to really have a conversation about what will healthcare look like in our community in 10 years if we don't convert and if we do. And so for us, I feel very strongly that our hospital, I would not be here today saying I'm from Mercy Hospital if we would not have made the decision to convert to REH in October of 2023 and filed the paperwork. I would be working somewhere else, maybe not even in the healthcare industry, I don't know, but Mercy Hospital would no longer exist if we would not have converted. And so because we made that decision, Mercy Hospital's in the strongest position that it's been in 10 years, and we have a bright future. And so that transition and engaging all those stakeholders together has made a tremendous difference for our community and ensured that we're going to have emergency care here. We're going to have outpatient hospital care here for years to come because of that.
Thank you very much, Aaron. Melissa, any closing comments that you want to share and part with folks?
Yeah, I would say in closing that if you're honest with your constituents and your employees in your community, it has been my experience that they respect that. If you're transparent and honest and have enough courage to do that, then I think in rural areas, people want to keep emergency rooms. They want their clinics. They want those outpatient services. They don't necessarily love that some things go away, and not everyone's happy about it. So I think it's really important to know that there will be some things that don't go super well with everyone you talk to about it, but I would say stay the course. If you feel like it's the right thing and you believe in it, then to be honest about it and communicate it in that way. If you don't feel it's the right thing, or if you have doubts, it is not going to be a good rollout, because people will be able to see that if you don't believe in it, then they shouldn't either. So I guess that would be my closing, is to be transparent and honest about it, and people generally will follow then, in a fairly positive way. And I guess my second thing is have a backup plan for cash if you can't bill for months.
Thank you very much, Melissa. Aaron, closing comments from you.
Yeah, we had a community town hall with our community stakeholders in October of 2023 before the paperwork was filed, to communicate, what we had been looking at and what our path forward was, to the point Melissa just raised about, we presented them a very clear and positive option for our community moving forward. And in that meeting, one of our community physicians, somebody asked the question, what do the doctors say? And that physician stood up in the public meeting and said, we have evaluated this option and this is the best route for our community. And so, showing that unity in the direction forward went a long ways for the community. And also at that same time, making the messaging about the services that were going to be added. We were already at the point of conversion looking at the walk-in clinic. Expansion of outpatient services and the infusion side came later, but we utilize a quarterly newsletter to keep that's mailed to our community at no cost, to keep them in contact with what's happening at the hospital, what services are we adding, new providers that we're bringing on. And so that continuous positive messaging with the community helps them realize, no, the hospital is not closed. The hospital is still very much here and alive, and we're adding more services all the time. And maybe inpatient went away. Right now, we don't have skilled nursing care at the hospital, but we have a lot of other services. For 92% of our patients, they interact with us just like they always have. And so that was really a key messaging piece for us, and continues to be, is that our values and why we're here for this, to serve the community, our mission statements, buy, love, serve one another, that has never changed and never will. And so making the messaging about that has really been a positive for our community.
Thank you very much, Aaron. I want to express appreciation to Melissa and to Aaron for taking time out of their schedules. They have a lot to do running hospitals, and we appreciate them sharing their lessons and their stories of where they're at. So thank you both very much. I'm going to turn it back over to Amy, who's just going to go through a few last couple of points.
Thank you, Ken. So we have some resources and next steps to share. As I mentioned earlier, the slides from today's webinar will be made available to you, and this resource listing will be included. We've consolidated several things that we thought you may be interested in exploring later. And again, this is just a reminder that you can find all of this information, as well as the recording, on our website within a week after today's event. If you're not already following us on social media, I encourage you to do so. We routinely post information that's not only relevant to rural communities in general, but specifically to the rural emergency hospitals. You'll see our website here at rhrco.org. Please reach out to us at any time through rehsupport@rhrco.org. We'll be following up with a survey link after this webinar. We encourage you to participate in that survey because we value your feedback on how we can continue to serve you and answer any questions that you might have. I want to extend a huge thank you to our CEOs, Aaron and Melissa, for their time today. We know your time is valuable, and we love that you're able and willing to share your experiences with us. And thank you, Ken, for your continued work in the rural health space and for sharing your expertise with us. Thank you, everyone, for joining us today. We look forward to seeing and hearing from all of you as you go through the journey and exploring the Rural Emergency Hospital as an option for your organization. Have a wonderful afternoon.